Hello, everyone. Welcome back to the Pediatric Question Hub. Here we learn smarter, retain longer, and feel more confident with every video. Let's learn endotracheal intubation and laryngoscopy in neonates. Neonatal intubation is a critical procedure where a tube is inserted into a newborn's trachea to secure their airway, often for mechanical ventilation. Card 1. Indications. Endotracheal intubation is indicated during neonatal resuscitation when there's no response to non-invasive positive pressure ventilation after corrective steps have been taken. It's also indicated in a few specific situations, like congenital diaphragmatic hernia, suspected airway anomaly like Pierre-Robin sequence, chonal atresia, moderate to severe respiratory distress not responsive to non-invasive support, need for surfactant administration, for example, in preterm RDS, if not using less invasive surfactant methods, anticipated deterioration during transfer, and during neonatal surgery or imaging under anesthesia. Card 2. Pre-procedural preparation. An easy mnemonic for this is SOAP-MM, suction catheter, oxygen for pre-oxygenation, a bag mask, and T-piece resuscitator. Airway use an appropriately sized endotracheal tube and laryngoscope, people including respiratory therapists and nurses. Monitor pulse oximetry, ECG, blood pressure, and capnography, and medications such as fentanyl, atropine, and succinylcholine to facilitate intubation. Card 3. Peculiarities of neonatal airway. Neonates' large heads cause natural neck flexion, compressing the soft upper airway. Their large tongues may fall back, increasing airway turbulence and obstruction. A short trachea, with a wide carina located higher up at T2 adults T4, increases the risk of mainstem endobronchial intubation. Larynx is higher and more anterior, C3, C4, making it more difficult to visualize. Epiglottis is U-shaped, long and soft and angled at 45, and may obscure the view of the vocal cords. This favors use of a straight blade. The cricoid cartilage is the narrowest part of the airway. It forms a natural seal with uncupped endotracheal tubes and avoids pressure injury at this site. Card 4. Unique features of neonatal pulmonary structure. At birth, the alveoli are immature and have a reduced gas exchange surface area, resulting in lower oxygen reserves. In neonates, small lung size and compliant chest walls result in low FRC. As such, they desaturate quickly during apnea or hypoventilation. Airway closure occurs at end expiration and can increase risk of atelectasis and hypoxia. High oxygen consumption due to high metabolic rate, 6-8 milliliters per kilogram per min in neonates. Card 5. Positioning for intubation. The image shows an infant in sniffing position using criteria 1, 2, and 3. 1. Align the glabella horizontally with the chin. 2. Open the anterior neck space. 3. Align the external auditory meatus with the suprasternal notch. Steps to achieve optimal sniffing position. Remember to assess criteria 1, 2, and 3 after each step. 1. Extend the neck with the infant on a flat surface, no shoulder roll or headrest, then check criteria. Sometimes this is all that is required. 2. Place a shoulder roll. 3. Add a headrest if needed. Card 6. Physiological stress responses to intubation. Adverse physiological responses to intubation includes bradycardia, systemic hypertension, intracranial hypertension, and hypoxia. Card 7. Hypoxia during intubation. Risk of hypoxia during intubation includes high oxygen consumption rate, low functional residual capacity, poor respiratory drive, inadequate pre-oxygenation, and prolonged intubation attempts without adequate oxygenation between attempts. Avoid hypoxia by preoxygenation. Use of a laryngoscope blade that allows continuous oxygen insufflation into the pharynx during the procedure, and muscle relaxation, which makes intubation much faster. Card 8. Bradycardia during intubation. The bradycardia is largely vagal in origin and occurs independently of hypoxia. It can be largely prevented by the use of atropine. Card 9. Intracranial hypertension during intubation. This appears to be the result of the infant's coughing and struggling and can be avoided by using muscle relaxants. Card 10. Systemic hypertension during intubation. Systemic hypertension is likely caused by increased vascular resistance from catecholamine release due to intense pain. Adequate analgesia helps reduce both blood pressure and stress hormone responses. Card 11. Importance of premedication in endotracheal intubation. Premedication reduces the physiological stress responses of bradycardia, systemic hypertension, intracranial hypertension, and hypoxia. It also decreases the pain and discomfort associated with intubation, facilitating the visualization of the vocal cords, potentially shortening duration of the procedure. Card 12. Contraindications to premedication. It is acceptable to intubate without premedication during emergency intubations for resuscitation or in infants where instrumentation of the airway is likely to be extremely difficult, those with severely abnormal airways who need to breathe on their own, or for infants with extremely difficult vascular access. Card 13. Optimal premedication protocol components. Administer a rapid-acting analgesic, a vagolytic, and a short-duration muscle relaxant. Use fast mnemonic, fentanyl, atropine, succinylcholine, and tube size. Card 14. Fentanyl, an opioid receptor agonist. Fentanyl is a rapid-acting analgesic with effective sedative properties. It has rapid onset of approximately 1 to 2 minutes and a short duration of action. Give slow infusion to prevent increased muscle tone chest wall rigidity, which can be reversed with naloxone or a rapid-acting muscle relaxant. Card 15. Recommended vagolytic for newborn intubation. Atropine is a muscarinic receptor antagonist, increases heart rate due to cholinergic blockade at the SA node and blocks vagally mediated bradycardia associated with intubation and reduces upper airway secretions. Give 3 to 5 minutes before initiation. Card 16. Muscle relaxant. Muscle relaxation avoids intracranial hypertension, make intubation faster, and lead to reduced hypoxia. Succinylcholine is a depolarizing neuromuscular blocking agent producing muscle paralysis. It has rapid onset of action less than 1 minute. Effects last about 2 to 4 minutes. Side effects include respiratory muscle paralysis with risk of apnea and pulmonary aspiration. It is contraindicated in hyperkalemia, family history of malignant hyperthermia, and severe sepsis. Card 17. Contraindications of midazolam and morphine in newborn intubation. Midazolam is a non-analgesic sedative associated with serious adverse effects like apnea, respiratory depression, hypotension, decreased cardiac output, and decreased cerebral blood flow velocity, and is associated with increased adverse neurological outcomes. Morphine is used cautiously in neonates due to its delayed metabolism, prolonged action, and higher risk of respiratory depression and hypotension. It requires at least 10 minutes for good analgesia after administration. Card 18. Uncurved endotracheal tube size. Uncuffed endotracheal tube reduces the risk of subglottic injury and pressure-related mucosal damage. For neonates weighing less than 1,000 grams, use size 2.5. 1,000 to 2,000 grams, use size 3. And greater than 3,000 grams, use size 3.5 to 4. Endotracheal tube insertion depth at lips is measured by adding 6 to the weight in kilograms. Cuffed ETT can be used in older children greater than 8 years old. Card 19. Laryngoscopes. In neonates, a straight blade lifts the epiglottis directly and improves the vocal cords visualization. Use Miller 1 for term, 0 for preterm, and 00 for extreme preterm. Card 20. Confirmation of intubation. The presence of exhaled carbon dioxide by a colorimetric device or a capnometer is the most reliable indicator of correct ETT placement. Secondary signs include auscultation of breath sounds, observation of symmetric chest rise. Chest radiography, ideal tube placement being at the mid-tracheal level, at the T1 or T2 level. Thank you for watching. Subscribe and turn on notifications to stay ahead in your pediatric journey.